Technical and medical. Decisions about care at the end of life are inherently difficult and stressful. Each patient is unique, as well as their healthcare issues. Therefore, there is no one-size-fits-all plan for medical care and treatment, especially if recovery is not possible and death becomes probable. Medical crises often take people by surprise, and the average person dealing with life is completely unprepared when they are suddenly spending time in emergency rooms, oncology offices, rehabilitation facilities, or hospitals. The sights, smells, and sounds are not familiar, nor are the words used by medical personnel making sense. It can be a scary and anxious time, especially if you're older, hard of hearing, have vision problems, are in pain, or are actually concerned for your loved one. It is in such times as these that knowledge can empower the patient and their family and can help establish a sense of calm. It is also in times like this that it is helpful to have had some conversations about expectations in possible health emergencies and who can or should be involved in discussing the patient's medical needs versus making healthcare decisions. The old adage about the more you are prepared, the better off you'll be is true. And it is why Anglicans for Life created a special curriculum called Embrace the Journey to help people prepare for aging and dying before we get into a crisis. There are a variety of healthcare services and support systems that become medical options depending upon the type of healthcare crisis or ongoing medical challenges that someone is facing. This section is designed to unpack two topics of care that the average patient and their family may encounter and will need to understand. First is advanced care directives, and second are various types of care needed. First, advanced care directives. Advanced care planning is available for Medicare and Medicaid recipients, and it allows patients' primary care physicians to talk with the patient about important decisions that can affect the type of care they receive and when they receive it. The Medicare recipient is encouraged to discuss their long-term health care goals, and these conversations can help a person to begin thinking about their priorities, preferences, and plans in case of a major illness or a terminal diagnosis. Certain questions can help people focus on aging and dying, such as, what are your end-of-life goals? What are your biggest fears and concerns about aging, illness, and dying? What goals are most important to you related to your style of living and your health care as you age or as you deal with pre-existing health issues? What trade-offs or compromises would you be willing to make? Questions that focus on treatment options should not be discussed, as it is impossible to make decisions about treatment for specific healthcare problems when they haven't actually occurred or been diagnosed. Do not answer these types of questions. Do you want or don't want life support? Do you want or don't want a ventilator to be used? Do you want or don't want antibiotics to be used? Do you or don't you want pain intervention to be used? Types of advance directives. There are 5 types of advance directives that are commonly considered when people are establishing their end-of-life documents, such as the last will and testament, revocable and irrevocable family trusts, and power of attorney for finances or health care. Some state laws vary and can impact existing documents if the person moves from one state to the other. There's no federal law requiring people to have advance directives to receive care in a hospital. Living wills were introduced in the 1970s as part of the Right to Die movement, enabling people to designate their preferences if they were physically or mentally incapacitated to make healthcare decisions. Also known as an advance directive, living wills require you to declare your preferences using generic statements such as the ones we used above, such as, I do or don't want antibiotics. I do or don't want life-sustaining treatment. Circling a do or a don't for general healthcare statements is problematic for two reasons. First, when someone chooses to say no to life-sustaining treatment, their choice may deny them care they actually want. Consider Sally. She's an 87-year-old female in good health and recently updated her living will to say she doesn't want life-sustaining treatment. She believed that meant she was saying no to extraordinary care like a ventilator when she's older. On their way home from the lawyer's office, she and her husband were in a bad car accident, and her left lung was punctured. At the hospital, she was put on a ventilator while they operated on her lung. Her daughter brought a copy of the newly signed living will to the attending physician. Based on the law and Sally's living will, the attending physician should remove Sally from the ventilator, which would cause her death. Or the second situation, which is when the second problem can arise. The attending physician, often referred to as a hospitalist, didn't know Sally. He didn't know her values, her healthcare history, or whether she wants to live, even if it means temporarily dependent on a ventilator. All the attending physician has to go by is the living will, which is a legal document. The daughter told the doctor her mother only meant no life-sustaining treatment at the end of her life, but Sally's son didn't agree with the sister, creating further confusion. Living wills and advance directives don't incorporate the myriad of variables that are the hallmark of a medical diagnosis and treatment options. Would Sally have expressed a desire for life-sustaining treatment if she had a proper understanding of what it included in the legal definition of such treatment? Did you know that insulin and even food and fluids provided via a feeding tube are considered life-sustaining treatment? Another type of treatment to be considered, physician orders for life-sustaining treatment. The acronym is POLST, P-O-L-S-T. It also goes by medical orders for life-sustaining treatment, MOLST. Both are actually medical orders that are legally binding and are effective once it is signed by a doctor. It includes sections on resuscitation, DNR and CPR, intubation, feeding tubes, pain management, and antibiotics. POLST or MOLST are different and separate from an advance directive or a living will. POLST is effective immediately versus a living will that serves as a guide for future healthcare decisions. Because a POLST form is a legal medical order, healthcare providers, especially EMS people, prioritize it in emergency situations. For example, if POLST specifies do not resuscitate, a DNR order, but a living will requests all life-saving measures, medical providers will follow the POLST form due to its clarity and legal weight as a medical order. This form is typically used for patients with serious, life-limiting medical conditions or who are extremely frail. A POLST form is typically printed on neon-colored paper and is kept in a visible place in the home or in the patient's medical record, and all healthcare providers have to honor its orders. While these forms can be necessary in limited healthcare situations, such as when a patient is in the final stages of death, they can also be used to prevent the provision of life-sustaining medical care, leading to a hastened death due to the lack of proper treatment. Another directive that is also included on the POLST form but may exist separately in a patient's medical record is a Do Not Resuscitate Order, DNR for short. DNR is a legal medical directive written and included in a patient's medical record according to the wishes of the patient who does not want CPR or advanced cardiac life support if his or her heart were to stop, or he or she stopped breathing. There are a few variations of DNR orders, but the only time it is appropriate to have one is if you or your loved one is near the end of life or in the last stages of a terminal illness. Trying to resuscitate an elderly, frail person can actually cause broken ribs if administered too aggressively. Families of patients must be cautious about consenting to a DNR, for even a patient with a terminal illness may have many years before he or she is actually near death. For example, someone with HIV would be considered terminal, but may live 20 or more years with the disease. So a terminal diagnosis should not be the baseline for having a DNR or Do Not Resuscitate order placed on their record. Also, we need to be vigilant about a DNR order being put on a patient's chart without consent from the patient or the patient's representative. This happened to a 12-year-old boy from Texas who was shot in the head. His doctor said his prognosis was poor. He was diagnosed as being in a persistent vegetative state, but he was breathing on his own. The doctor secretly withdrew the boy's food and water directives and slipped a Do Not Resuscitate order into his chart without his parents' knowledge or consent. His mom had to fight to get the DNR order removed, and it is a good thing she did, as the young boy went on to make a full recovery. A study presented at the American Surgical Association's annual conference found that elderly patients who sign preoperative DNR orders are more likely to die from surgical complications because the DNR order effectively prevents aggressive treatment if they do have complications. Long-term care insurance. Long-term care insurance has been popular for more than 40 years and has evolved based on changes in people's care preferences towards the end of life. This type of insurance helps cover costs for services not typically included in regular health insurance or Medicare, such as assistance with daily activities, bathing, dressing, eating, due to chronic illnesses or disabilities. This type of insurance is purchased before someone actually knows what type of care they will need, but is designed to help offset the costs once they are being incurred. Long-term care insurance essentially covers services that are provided in settings like nursing homes, assisted living facilities, or at home. Key features of long-term care insurance include policies may cover nursing home care, assisted living, home health aides, adult daycare, or respite care. Comprehensive policies include covering multiple settings, while some are limited to specific types of care, such as institutional or home-based care. Benefits typically kick in when the insured person cannot perform 2 or more activities of daily living and has a cognitive impairment requiring supervision. Premiums depend on health, age, coverage amount, benefit period, and inflation protection. For example, a 2024 average policy cost of $300 a month, but the premiums can rise over time, especially for traditional policies. Most policies reimburse costs up to a daily or monthly limit, though some offer cash benefits. The lifetime maximum is set by daily amounts times number of days covered and should be carefully reviewed before any commitment is made. The best advance directive is called a Power of Attorney for Healthcare, POA. This requires a legal document that appoints someone to serve as a proxy or advocate if the patient is incapacitated, either permanently or temporarily, or is limited in understanding their condition, or is no longer capable of comprehending their medical problems. A power of attorney for healthcare is the best choice for an advance directive, and we strongly recommend them over all other types of documents. Appointing a POA allows them to make healthcare decisions for the patient based on actual medical data and test results, as well as the patient's preferences, without being limited or controlled by a document with checked boxes like a living will. A POA for healthcare can speak to your doctors for you, can make choices about your medical care or services like tests or medicine or surgery. This care or service could be to help find out what the healthcare problem is or how to treat it. It can also include care to keep you alive. If the treatment or care has already started, your healthcare advocate can keep it going or have it stopped if it's burdensome. The POA can interpret any instructions you have given according to your healthcare advocate's understanding of your wishes and values. Your POA can consent to admission to an assisted living facility, hospital, hospice, or nursing home for you. Your advocate can hire any kind of healthcare worker you may need to help you or take care of you. Your advocate may also dismiss or change a healthcare provider if needed. The POA can also make the decision to request, take away, or not provide medical treatment, including artificially providing food and water or any other treatments to keep you alive. The POA can see and approve the release of your medical records and personal files. If you need to sign your name to retrieve any of these files, your advocate can sign for you. Your POA can move you to another state to obtain the care you need to carry out your wishes. Your POA can authorize or refuse to authorize any medication or procedure needed to help with pain. Your power of attorney can take any legal action to carry out your wishes. They can also donate usable organs or tissues as allowed by law, based on your preferences. They can also apply for Medicare or Medicaid or other programs or insurance benefits for you. Your advocate should be able to see your records to find out what is needed to fill out any forms required. Please note that a power of attorney for healthcare is separate and different from a power of attorney for finance. The same person can be appointed for both. Choosing a power of attorney for healthcare can be challenging. He or she must be someone who knows and cares for the patient. They must be able to make difficult decisions and remain calm in crisis. They should be nearby and available if needed. Whoever is chosen as the POA, it is critical for them to have an in-depth conversation with the patient to discuss and understand the patient's wishes and be willing to follow and respect the patient's wishes. After appointing someone as power of attorney for healthcare, be sure to do the following. First, give them a copy of the signed form so they can share it as needed. Make sure they have the names and contact information for all your healthcare providers as well as your insurance. Make sure your primary care provider knows the name and contact information for your POA. It's also helpful to give them a copy of the POA. Types of care that may be needed. While most acute medical care begins in a hospital setting, secondary or extended care will often require the patient to be transferred to another facility. It is even common to see a patient moved to multiple care facilities depending on a variety of issues, such as room availability, mobility, physical therapy needs, finances, insurance, home circumstances, and long-term versus short-term needs. One facility that you might go into is a nursing home. Nursing homes are considered is a generic term used to describe a facility that provides care. But actually, there are a variety of types of nursing home accommodations available to care for a patient depending on their needs. Here is an overview of the main types. Skilled nursing facilities. These places provide 24/7 medical care for seniors with serious health conditions or post-hospital recovery needs. They offer skilled nursing, physical therapy, and assistance with daily activities. Assisted living facilities focus on seniors who need help with daily tasks, bathing, dressing, meals, but don't require constant medical care. Emphasis should be on independence with social activities and some medical oversight. There are also memory care facilities. They specialize for people with Alzheimer's or dementia, and they offer secure environments that are with structured routines and staff trained in memory-related care to manage cognitive decline. There are also continuing care retirement communities. They combine independent living, assisted living, and nursing home care on one campus. Residents can transition between levels of care as needs change, ideal for long-term planning for families. There's also board and care homes. These are smaller residential settings offering personalized care in a home-like environment. They provide assistance with daily activities and some medical support, suited more for those preferring less of an institutional feel. And then there are rehabilitation centers. These are short-term facilities focused on recovery after surgery, an illness, or an injury. They offer intensive therapy, often physical, occupational, and speech, to help seniors regain their independence. Each level of care varies in cost, care needed, and environment, so the choice will depend on the patient's health, budget, needs, and preferences. Hospice care is another type of care that may be familiar to many people. Hospice care focuses on providing comfort and support to individuals with terminal illnesses who are nearing the end of life, typically with the prognosis of 6 months or less to live. Its emphasis is in keeping the patient comfortable instead of curing the illness, and often includes addressing physical, emotional, and spiritual needs to prepare for dying. Hospice care can be provided in various settings, including the home, which is most common with care from hospice professionals coming in and family support as well being provided. There's also hospice in the nursing home for residents already in a long-term care facility. There are actually also hospice facilities, dedicated centers for end-of-life care. And then there are hospitals when patients just need short-term symptom management, but the hospice services follow the patient. Services under the hospice banner can include pain and symptom management, also known as palliative care, emotional and psychological support for patients and for their families, assistance with daily activities such as bathing and dressing, spiritual counseling if desired, and bereavement support for families after the patient's death. For elderly individuals in nursing homes, hospice care can be integrated into their existing care plan. Many nursing homes partner with hospice providers to deliver services on site, allowing residents to stay in familiar surroundings. Long-term care insurance may cover some hospice costs if included in the policy, but Medicare typically takes precedence for eligible patients. Hospice care is delivered by a team of professionals including doctors, nurses, social workers, chaplains, and volunteers. To qualify for hospice, particularly under Medicare or most insurance plans in the United States, specific criteria must be met. They are as follows: terminal illness diagnosis. A physician must certify that the patient has a life expectancy of 6 months or less if the illness runs its expected course. This prognosis is based on the patient's medical condition and decline trajectory. Common qualifying conditions include advanced cancer, heart failure, COPD, Alzheimer's or dementia, kidney failure, or ALS. Certification by a physician. 2 physicians, typically the patient's primary care doctor and a hospice medical director, must confirm the terminal diagnosis. The certification must be documented, and recertification is required if the patient lives beyond 6 months. Acceptance of palliative care. The patient must agree to forego curative treatments, i.e., chemotherapy for cancer, in favor of comfort-focused care. This means stopping treatments aimed at curing the illness, though treatments for symptom relief will continue. Patients can revoke hospice care to resume curative treatments and then re-enroll if needed. Hospice is not limited to the elderly. Anyone with a qualifying terminal illness can enroll. Choosing a reputable, licensed hospice provider is very important. Medicare's website, medicare.gov, or state healthcare departments can provide a list of providers. The patient or their family has the right to interview hospice agencies and choose one they feel aligns with their values and priorities for the patient. Families often delay seeking hospice care due to the emotional difficulty associated with accepting a terminal prognosis. Hospice does offer counseling and education for families, which can be helpful, especially if the family is not coping well. Withdrawal of care. A point may come in the treatment process for a patient when a discussion needs to occur about ending a specific treatment plan. This can happen for a number of reasons, such as the medical intervention isn't beneficial to the treatment of the illness, or the treatment becomes burdensome for the patient, or it is preventing the patient from fulfilling their end-of-life goals. Stopping a specific treatment may cause natural death to occur sooner than if treatment had continued, such as with dialysis. Withdrawing care should only occur in rare circumstances, and the only people who can make that decision is the patient or their power of attorney for health care, and the decision should align with the patient's end-of-life wishes. How care is withdrawn is important and should not employ the following 3 methods. You should not look at futile care, even though it is similar but distinctly different in that the decision to stop treatment is made by the medical team and the family may or may not be consulted. Typically, it is a doctor or a hospitalist who judges the treatment as futile and believes it is wasting resources or giving the patient false hope of recovery. Defining futility is complex and can be controversial, as patients and their families and the healthcare provider may disagree on what is or isn't beneficial for the patient. Choosing to end or withhold treatment should never include stopping food or fluids unless death is imminent or the patient is choosing not to eat or drink. If the patient is being fed through a feeding tube, withdrawal of the feeding tube will lead to dehydration and starvation and death. Once a feeding tube is in place, it should remain to ensure the patient can receive nutrition and hydration. Another form that is unacceptable is voluntarily stopping eating or drinking, also known as VSED. It is a specific form of withdrawing care, stopping food and fluids, but it is patient-initiated and focused on hastening death. Whereas withdrawal of care broadly includes stopping all life-sustaining treatment, which it can include a ventilator, for comfort or futility reasons. While VSED respects autonomy, some argue it can feel coercive if driven by lack of other options to access good care. VSED is a form of starvation and causes dehydration and is physically very painful to endure. Terminal sedation can accompany withdrawal of care and, if used aggressively, will hasten the dying process. Terminal sedation places a patient under anesthesia during the dying process. Supportive care is stopped and the patient is given a sufficient amount of drugs to render them unconscious. An article titled A Declaration on Assisted Dying, authored at the 13th International Conference of the World Federation of Right to Die Societies in the year 2000, describes the practice of terminal sedation as something done regularly throughout the world in hospitals, nursing homes, hospices, and in private homes. It is carried out under the doctrine known as double effect, by which a physician may lawfully administer increasing doses of a regular anesthetic or sedative drug that can hasten someone's death, as long as the declared intention is to ease pain and suffering. Their double effect doctrine is discussed in depth in the article Stealth Euthanasia and is a reference in the list. To prevent a loved one from becoming a victim of it, the power of attorney can work with the medical staff to identify the lowest dose of sedation that prevents discomfort but doesn't cause an unconscious state. When the patient is put into a state of unconsciousness, the dying person is deprived of being present at the end of their own life. It undermines their humanity and personhood. It can also deny family members the opportunity to have time with the dying person. According to Hospice Patients Alliance, terminal sedation is becoming more and more common in hospice situations and is used in effect as a means of slow euthanasia, where the family and/or healthcare professionals are not willing to openly admit they are choosing to end the life of a patient. It is often done routinely without the patient's knowledge or permission, and it outwardly appears to be a peaceful death. Complete sedation of a patient is only appropriate when the patient is already actively dying and severely agitated. They're in a delirious state, or when sedation combined with pain medicine is being used to manage extreme uncontrollable pain. Sedating patients in these rare circumstances manages the symptoms but does not cause death, as does terminal sedation. Comfort care and palliative care are two different types of care that are often confused because healthcare professionals sometimes use these terms interchangeably. Comfort care focuses on keeping the patient comfortable when the decision is made to stop seeking a cure for an illness. A cancer patient may decide to stop chemotherapy or radiation because it has become too burdensome and is no longer effective in preventing the cancer from advancing. Palliative care would then be employed to help manage pain using various medications to keep the patient comfortable and pain-free. Palliative care is for people of any age and at any stage in an illness, whether they are chronically ill or if it's curable or if it's life-threatening. Palliative care is in essence about pain and symptom management. It has become a specialized field of medicine and should be included in caring for every patient that is experiencing any level of discomfort, regardless of age or status of health. Whether either of these terms are used by medical professionals, it is critical to ask for clarification to ensure the family and patient understand what type of care is being referred to in every discussion.